So we're going to see a 39-year-old man that presented to the office for evaluation of progressive dyspnea on exertion. Again, dyspnea on exertion could be many things. This is a young guy of 39 years old, okay? He's also complaining of swelling of his legs. So he's got a little bit of what appears to be actually maybe a little bit of fluid overload with dyspnea on exertion. Actually, it could be actually the heart, the kidneys, the liver, right? Okay, so let's see where the problem is. He says that the actual swelling of his legs, okay, has also worsening, okay? He's on a combination of furosemide, so he's on a diuretic already, and he is on hydrochlorothiazide as well, okay? So he's on 2 diuretics, which has not controlled his symptoms. So diuretic itself has not controlled the symptoms, but we don't know what the patient has. Let's see what's the problem here. Heart auscultation revealed a 2/6 systolic murmur, best heard on the lower left sternal border that radiates to the carotid. So a systolic murmur on the left sternal border. The murmur increases with Valsalva and decreases with squatting. Now, these maneuvers should help you identify the murmur. Let's see here. What murmurs? First of all, this is not at the apex. This is actually a murmur that is best heard on the lower left sternal border that's radiating upwards to the carotid, right? Okay. Let's see here. The murmur increases with Valsalva and decreases with squatting, and there is a prominent S4 gallop. What does the S4 gallop tell you guys? The S4 gallop is telling you that the patient has a weak heart or a thickened heart. Left ventricular hypertrophy, right? So hypertrophy. So let's see here. Let's look at this here, okay? The murmur increases with Valsalva. Valsalva, what does it do to the venous return? Does it increase the venous return or decreases the venous return? Decreases the venous return. The murmur gets worse when there is actually less blood in the heart, okay? Now, which murmurs gets worse with less blood in the heart? There's 2 murmurs that we know. Yeah, mitral valve prolapse and hypertrophic obstructive cardiomyopathy. The location of this murmur indicates that the murmur is best heard, okay, in the sternal border. Is that mitral or is that more hypertrophic obstructive cardiomyopathy? I think Patricia is saying hypertrophic obstructive cardiomyopathy. Yes, okay. Now let's look and see if this other maneuver actually goes with hypertrophic obstructive cardiomyopathy. Squatting increases the venous return, and with more blood, the murmur gets better. So that is one condition. There's no other condition that does that, right? Now, let's see here. The actual carotid pulse is brisk, so it's strong, okay? So the heart has enough force, but it's bifid. It has like two step to it. Shh, 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 shh. Like it sounds like it's double, right? And the lower extremity revealed 2+ bilateral pitting edema. So this should be not very difficult. The EKG reveals biphasic P waves. What does this biphasic P wave? Exactly, Hector, not a faucet, right? What is this biphasic P waves tells you? Yeah, there's dilation of the left atria. And the left axis deviation. How do we find left axis deviation on an EKG, guys? Left axis deviation. Tell me what wave is going to be, what lead is going to be downward. Inversion of lead, AVF. Yes, AVF. AVF is going to be downward while lead 1 is going to be upright. Okay? So now you know how to actually detect it. When you actually have left axis deviation, think of left ventricular hypertrophy as the most common cause of left axis deviation. Which of the following is the next step in the management of this patient? So let's see here. The patient has dyspnea on exertion, right? So I would probably want to do a chest x-ray on this patient, right? The patient has a murmur, so I want to do actually and check out why the purpose has a murmur. So an echo would be a good study to do. They already did an EKG, so an EKG is not necessary to be done. So let's see here. Which of the following is the best next step in the management of this patient? My question to you guys is the following. Have we confirmed the diagnosis, yes or no? So far, we haven't confirmed the diagnosis. Have we suspected a diagnosis, yes or no? So the next step in the management of a patient after you suspect the diagnosis would be to do what? Suspect, and then confirm, and then treat, right? Okay, so let's see if they're asking us to confirm or to treat. Let's see. Start an ACE inhibitor on this patient. We could start an ACE inhibitor, but I would probably want to confirm first with an echo, right? Okay. Refer to a cardiologist. You're not going to refer to a cardiologist. Perform an echocardiogram. I like that one better before the ACE inhibitor to make sure that I'm doing the right thing. Perform a treadmill stress test. Are you gonna put this patient to run on a treadmill? Let's talk about actually exercise as a maneuver and how it affects the different murmurs, guys. Exercise. Exercise. What is exercise does to the actual heart rate, okay? It increases, let's just talk about the heart rate, right? The heart rate. Increases the heart rate, right? Okay. So during exercise, what happens to the time that the heart has to fill up during diastole in exercise? It's less, okay? It's less, okay? So therefore, these patients are going to actually have less blood coming into their heart, right? If they exercise, right? If they have hypertrophic obstructive cardiomyopathy and you have less heart in the actual, less blood in the heart, what's going to happen to the obstruction? Worsens, right? Okay, I see Jacine, Sarah, and all of you are saying it, right? So, is it a good idea to actually have a patient with hypertrophic obstructive cardiomyopathy exercised on a treadmill? No, because if you put him to exercise on a treadmill, what's going to happen to the patient? He'll die, right? Remember that hypertrophic obstructive cardiomyopathy is one of those conditions that can present with what symptom did I say yesterday at the beginning? They have collapse, sudden death, but something else. They can present also with chest pain. And remember, what type of chest pain is it? Is it stable angina, unstable angina, or does it sound like a myocardial infarction when they present? It sounds like stable angina, right? How do we treat how do we make a diagnosis of stable angina many times on a 39-year-old? What's the best test to make a stress test, right? And what type of stress test would you use if a patient is 39 years old and he can walk? An exercise stress test. And when you make that patient exercise because he's had stable angina, what's going to happen to the patient if you didn't check that the patient had hypertrophic obstructive cardiomyopathy? Die, right? You don't want to do that. Now, let me ask you another question here so you understand where the questions are going to come from. If a patient has hypertrophic obstructive cardiomyopathy, right? A patient that comes to you with stable angina, what are the first drugs that we give the patient? We give them aspirin and we give them something else. What is the actual anti-anginal drug that we use in patients with angina? Nitroglycerin. Now let's talk about nitroglycerin as a drug and how it affects the actual hemodynamics of the heart. Nitroglycerin, what does it do to the actual peripheral? It's a venodilator, right? So what does it do to the venous return? Reduces the venous return, reduces the amount of blood that's coming into the heart, right? If you reduce the amount of blood coming into the heart, what's going to happen to the obstruction in hypertrophic obstructive cardiomyopathy? Jacine, gets worse, right? So if you give a patient actually nitroglycerin with hypertrophic obstructive cardiomyopathy, what can happen to the patient? Exactly. So you give a patient who's young, okay, that comes to you with stable angina, you don't listen to his heart, and you give him nitroglycerin. If the patient dies, it's your fault, okay? So you cannot give a patient nitroglycerin that comes with stable angina unless you listen to their chest and make sure there's not a murmur. Because if there's a murmur there, the first thing you need to do is make sure that this patient doesn't have actually hypertrophic obstructive cardiomyopathy, because if not, you're going to kill the patient. That's what you have to know for these, okay? So make sure you know that. So perform an echo, confirm your diagnosis, and make sure that this patient has actually hypertrophic obstructive cardiomyopathy. If he doesn't have hypertrophic obstructive cardiomyopathy, then you can use those drugs. But if he does, no. Okay. Victor 1, what was that? Are you okay there? Any questions? Wow. So what's the answer here? What are you going to do, Kamini? If a patient comes to you with this, how do you confirm it? Absolutely. C. Do an echocardiogram, okay? Because you cannot use any of the other. Can you imagine if you start the patient on hydralazine, okay, or isosorbate nitrate, okay? You're going to kill him, right? So not a good idea. Perform an echo before, because if patient actually has hypertrophic obstructive cardiomyopathy, okay, what you would do for those patients, what would be the drug that you would give those patients? And we're going to talk about it in a second here. A beta blocker. Let's look at the results of the echocardiogram of the patient. The echocardiogram shows thickened ventricular septum, which is hypertrophy disproportionately to the posterior wall of the left ventricle and measured 22 millimeters in thickness. There is an anterior displacement of the mitral valve apparatus during systole, and there's a diastolic dysfunction with an ejection fraction of 65%. So as you can see, this patient has diastolic dysfunction. No, Allison. Sildenafil is only given for patients with pulmonary hypertension. Okay? Now, in reviewing these patients' history, you recognize that his condition places him at increased risk for, so hypertrophic obstructive cardiomyopathy puts the patient at increased for, Jacine, you got that, sudden cardiac death. Remember that these patients actually will develop sudden cardiac death if they actually have hypertrophic obstructive cardiomyopathy, for example, if they're actually exercising too much. Because if they exercise, now you know how exercise actually affects hypertrophic obstructive cardiomyopathy and why these patients can develop sudden cardiac death. If you actually completely obstruct the outflow of blood out of the heart, these patients are going to actually not going to have any blood going, not even to the myocardium, not even to the CNS. These patients are going to have a syncopal episode. The heart, they can go into ventricular fibrillation and develop actually sudden cardiac death. Okay, so very important for hypertrophic obstructive cardiomyopathy to remember that these patients actually are at increased risk of sudden cardiac death. They should not actually perform very vigorous activity because that actually can precipitate it. How do patients with hypertrophic obstructive cardiomyopathy present? They can develop dyspnea on exertion because of the congestive heart failure. They can develop stable angina. I told you already that there's a couple of conditions that cause a stable angina other than coronary artery disease, which is aortic stenosis, aortic regurgitation, and hypertrophic obstructive cardiomyopathy. They can develop syncope and pre-syncope, okay? They can develop palpitation, and they can actually develop sudden cardiac death, which might be the first manifestation of the actual disease. The patient might not have any other symptoms, and all of a sudden, the patient actually, you see some athletes that have never had any problem, and all of a sudden, you know, they die while they're actually playing a game, okay? It's typical of hypertrophic obstructive cardiomyopathy.